Hi, my name is Dong He, and I'm a third-year medical student here to present my project on the association between U.S. Pediatric Trauma Center access, injury burden, and socioeconomic disadvantage. This project was conducted with a few other colleagues, Alex and Tiffany, along with my supervising resident, Dr. Jeff Choi, and supervising attending Dr. David Spain. As an introduction, traumatic injury is the leading cause of pediatric mortality in the U.S. The CDC reported that there are roughly over 7,000 pediatric deaths recorded in just the year of 2019. Having prompt access to these pediatric trauma centers is a key determinant factor of outcomes, particularly mortality. However, we know that racial, ethnic, and rural urban disparities in access to pediatric trauma centers still persist. We hypothesized that in our study, that areas with high pediatric injury burden and socioeconomic disadvantaged regions lack timely access to these pediatric trauma centers. Coming to our methods, pediatric population was defined as less than 18-year-olds. We calculated air and ground transport time from each census block group to the nearest ACS verified pediatric trauma centers. Block group level geolocation and demographic variables were acquired from the 2019 ACS American Community Survey data, and ACS verified level 1 through 3 pediatric trauma center geolocations were from the 2019 Trauma Exchange Information Program dataset. Air travel time was defined as the sum of the flight path from the nearest air medical service base to the block group and from each block group to the nearest pediatric trauma center. And ground travel time was based on the optimal driving route from each block group to its nearest pediatric trauma centers using Valhalla and OpenStreetMap program. To analyze the pediatric trauma center injury burden in each state, we used state-specific fatal injury data from the 2019 WISCARS dataset and non-fatal pediatric injuries recorded from the HCUP FASTStat dataset. Lastly, we use ADI from 2020 Neighborhood Atlas dataset as another marker of disparity at the census block group level. The values of these ADI ranges from 0 to 100, 0 being the least disadvantaged and 100 being the most disadvantaged. And the ADI constant accounts for multiple variables, including disparities in income, education, employment, and housing quality. In 2019, coming to our results, there were 73 million pediatric population with 5 million non-fatal injuries and 8,000 fatal injuries. From our analysis, 68.8% of fatal injuries were within level 1 pediatric trauma centers and 77.4% if we expand to level 1 through 3 pediatric trauma centers. Coming down to our second analysis of geographic disparity in supply and demand for pediatric trauma centers, we have created a scatter plot here with percent of national fatal injury per state on the x-axis and the percent population with 60-minute access to a pediatric trauma center on the y-axis, with each point corresponding to a state and colored based on U.S. Census Bureau region. Southern states had disproportionately higher national fatal injury burden and lower 60-minute access to a pediatric trauma center, as you can see on the bottom right quadrant of this figure. On the other hand, Northeast state had lower national fatal injury compared to the national median value and had greater access to these pediatric trauma centers. For our third analysis, we found that socioeconomic disparity was negatively correlated with pediatric trauma center access. We have created this bar plot on the right lower quadrant with area deprivation index on the x-axis with median census block group travel time to a pediatric trauma center on the y-axis. And we can see that there's a positive correlation between these two variables. What this means is that as neighborhood disparity increases, the time it takes to get to the nearest pediatric trauma center also increases as well. So in conclusion, some states with high fatal pediatric injury burden disproportionately lack timely pediatric trauma center access, as we can see on our figure 1. We also saw in this figure that there were regional disparities in injury burden and pediatric trauma center access, particularly in the South. But more granular injury burden data is really needed to inform any policy changes at the local level. We also found, as seen in our bottom figure, a positive trend between socioeconomic disadvantaged neighborhood and travel time to these pediatric trauma centers. Now, one could argue that children can be treated at adult trauma centers. However, prior studies have demonstrated that treatment at pediatric trauma centers compared to adult trauma centers has been associated with lower mortality, particularly in the ages 16 and younger. Of course, this line becomes less clear as children grows older and reaches adulthood. For future directions, really more thoughts need to be made in where these pediatric trauma centers are developed to maximize coverage in areas where there's already lower access and higher injury burdens. And really more resources need to be placed to maximize pediatric readiness, not only in pediatric trauma centers, not only in adult trauma centers, but also in pediatric trauma centers as well. I would like to just thank all my colleagues and mentors who have helped me on this project, and I really appreciate your time listening to my project on the association between U.S. Pediatric Trauma Center access, injury burden, and socioeconomic disadvantage. Thank you.